I'll
Yes, okay.
start, ma'am.
Yeah.
Good evening, everyone. Welcome to our monthly academic session. So today our discussion would be on anemia in pregnancy. The speaker for today is Dr. Sirisha. She is a second year Diploma of Family Medicine student at District Hospital, Kolar. All the best, Sirisha. And the moderators for today are Dr. Sri Lakshmi. She has done her MS and MRC OG UK, and she's the consultant obstetrician and gynecologist at Rangadure Memorial Hospital. She's also a DNB trainer and examiner, and she's a part of South Bangalore OBGYN team from its very beginning. Welcome, ma'am.
Thank you.
And our second moderator for the day is Dr. Jyotika Gupta. She has done her DNB Family Medicine and MRCGP International, fellow in diabetes mellitus. She's practicing presently at RxGS Samanvaya, a primary care clinic in Malleshwaram. She's also the executive member of AFPI Karnataka chapter and the national secretary, the Spice Route India movement. Welcome, ma'am.
Thank you, Akshaya.
Yeah, Sirisha, I think you can take over now and start the session for today.
Yeah.
Okay. One more announcement. Request all the participants to enter your complete name and not the Samsung or Redmi or mobile names. Kindly rename yourself.
Sorry for the interruption, and anyone has any doubts or questions, kindly type it into the chat box and it will be addressed at the end of the session once the presentation is done. Thank you.
Let's start, ma'am.
Yeah, start.
Yes, yes.
Today I'm going to present anemia and pregnancy. Coming to the patient particulars. So a 22-year-old female lady by name Swarna, wife of Mr. Vijay, resident of Srinivasapura, Kolar. Her occupation is daily wage laborer. Her education is unschooled. Her husband's occupation is daily wage laborer, and husband's education is unschooled. They belongs to lower socio-economic status. Date of examination is 22nd September 2023. Shall I go to next slide, ma'am?
Continue. Yeah, continue.
She is a primary gravida with 8 months of amenorrhea. Her chief complaints are complaint of easy fatigability for past 2 months, complaint of swelling of both lower limbs for past 1.5 months, complaint of breathlessness on exertion since 15 days.
You finish your history.
Okay, ma'am. History of presenting illness. Complaint of easy fatigability and generalized weakness since 2 months. Patient was apparently normal 2 months back, then gradually developed easy fatigability and generalized weakness. Previously, the patient was able to manage work and household works, but since past 2 months, gets tired on minimal work. History of swelling of both limbs since 1.5 months, which was aggravated on standing and walking, relieved by taking rest. History of
Hello.
Sirisha, your voice is
aggravates
breaking.
and prolonged walk.
Hello, your voice is
No bleeding per vagina, bleeding per rectum, hematemesis, passage of worms in stools, chest pain, or syncope. Ma'am, are you audible, ma'am?
No, it's breaking. Your voice is breaking,
Voice
Sirisha.
is breaking.
Hello?
Yes, Sirisha, continue. Say something.
No history of palpitations, chest pain, or syncope. No history of bleeding per vagina, bleeding per rectum, hematemesis, or melena, easy bruisability. No history of passage of worms in stools. No history of jaundice. No history of previous blood transfusions. no history of reduced appetite, no history of constipation, no history of burning micturition, no history of increased frequency of micturition, no history of fever or chronic cough, no history of numbness, no history of tingling sensation, no history of headache or blurring of vision.
I mean, can I take start with the questions? Can you go back to your first slide?
Yes, ma'am.
Yeah. I mean, I know whether I don't know whether in the exam they will allow you to tell the name. So probably it is better you address them with X, Y, Z. And also the other thing I wanted to ask you is what is this unschooled? I think better word will be illiterate or uneducated, something like that. Okay, so just need some corrections here. Okay. So unschooled is uneducated is better terminology than unschooled. Okay.
Yeah, have they studied at all, Sirisha, or how is it? And can they read and write? Both of them.
Hello, Dr. Sirisha, can you hear us?
Hello, Sirisha, your voice is
Your
breaking.
voice is breaking.
Okay.
Hello.
I
Hello,
think
ma'am.
she's logged out. Maybe she's trying to log in again.
Okay. Did she join?
Not yet.
Not it, not it. Yeah, I think she's there.
Hello.
Hello, ma'am. 1 second, ma'am. I'm checking with.
Cannot see her name, Akshay. Can you
Ma'am,
see
I,
her?
yeah, I see her name on the thing in the participant list. It still says co-host, Dr. Sirisha.
Sirisha. Yeah. Sirisha, are you there?
Yes, ma'am. I'm
Okay. Your screen share went away. Yes, it's visible now.
ma'am. Are you audible, ma'am?
Yeah, we can hear you,
We
Sirisha.
are audible. Yeah, we can hear you as well. Yes, Sirisha. We were talking about the first slide about the patient details. Can you hear us?
Yes, ma'am. I'm able to hear
Okay.
you.
So, Dr. Sri Lakshmi is also saying not to say unschooled. And my question was, are they illiterate or can they read and write but have not gone to school? What is it?
Probably you can put it as uneducated. That's a
That's what.
better word than
Illiterate,
unschooled. Okay.
illiterate or uneducated?
You can't.
Sirisha, your voice is breaking, ma.
Okay, ma'am.
Yeah, now we
Okay,
can
ma'am.
hear you talk.
The second thing, since it's a family medicine, how do you assess the socioeconomic status?
Yes.
What is that scale you use? Can you brief us?
Ma'am, what question, ma'am?
The socioeconomic status.
Socioeconomic status, two scales we will use, ma'am. Kupuswamy classification and BJ Prasad classification. In Kupuswamy classification, income, education, and then profession we will consider, ma'am.
Okay.
Hmm.
So you assessed based on that and you put it as a lower socioeconomic.
Lower socioeconomic status, ma'am.
I think it's one of the major questions for you in the exams in the
Yes.
other subjects. So go to the next slide. So what are her chief complaints are easy fatigability and swelling of both the lower limbs and breathlessness.
Yes, ma'am.
So based on your chief complaints, when you take a history of presenting illness, you have to make some decision in your mind or some conclusion in your mind. Probably you need to elicit a history looking at these chief complaints. Now, what are the differential diagnoses that come to your mind in any pregnant lady? Complaints of fatigability, swelling, or breathlessness. What are the differential diagnoses comes to your mind? It flashes through your mind. So that's how you should assess, right? When the patient comes to the
Yes,
OPD.
ma'am.
She comes
Easy fatigability you can see in anemia, ma'am. Swelling of both limbs and breathlessness we can see in any cardiac illness also we can see, ma'am. Swelling of limbs we can see any in renal impairment or liver failure also we can see, ma'am.
Can pregnancy itself cause swelling of both lower limbs?
Yes, ma'am. Physiological edema it will cause, ma'am.
Yeah.
What is the cause for that?
Decreased venous return.
Secondary to
Decreased venous return due to more abdominal gravid uterus, ma'am.
That gravid uterus pushing on something.
It will push inferior vena cava, ma'am.
so there's a compression of the inferior vena cava by
Okay, ma'am.
gravid uterus. But if at all you see any swelling in the lower limbs in the early pregnancy, so when did the uterus become an abdominal organ in pregnancy? You see
After
it in
12
third
weeks, ma'am.
Huh?
After 12 weeks, it will become abdominal organ, ma'am.
To cause a pressure, probably after second trimester, most common we see after 28.
Yes, ma'am. During second
So, yeah.
trimester.
And what type of edema is that? What are the different types of edema? You see in the
Pitting
book.
and non-pitting type of edema, ma'am.
Okay. So what do you see in pregnancy? Physiological edema is pitting or non-pitting?
It's a
When
pitting
do
type
you
of
see
edema,
non-pitting
ma'am.
edema?
Pitting edema, ma'am.
Yeah. When do you see, in what conditions do you see non-pitting edema?
Mixed edema we can see, ma'am. And then any lymphedema is there also we can see, ma'am. Non-pitting edema.
And usually the physiological edema of pregnancy towards the end of the day. And early morning when she gets up from the bed, you should ask, do you see the legs being swollen even in the early hours of morning when you get up from the bed? If she tells it's only at the end of the day, probably it is more of a physiological edema, which is caused because of the pressure of the gravid uterus on the inferior vena cava, impairing the venous return. Okay. So how do you classify breathlessness?
Newark class, NIHA classification, ma'am. Newark Heart Association classification.
Yeah.
4 grades are there, ma'am. Grade 1 is no symptoms with ordinary activity. Grade 2 is limitation of activity will be there, mild limitation of activity. Grade 3 is marked limitation of activity. And then grade 4 is at rest also she will be dismissed.
So she's in which grade? Now, according to your
She
chief.
will be grade 2, ma'am.
Okay. So the next, can you show the next slide? So you have elaborated the history of presenting illness and chief complaints have been elaborated well taking into consideration. Now, do you have to take now because you have to made a DD? You said only anemia and pregnancy. What are the other conditions which can cause this fatigability, weakness, and lower limb edema? The other condition. Cardiac. The patient is
Cardiac
cardiac.
causes will cause, ma'am.
And go. So your next history in elaborating the history of presenting illness, you have to take a history pertaining to these conditions also. So when you go to the next slide. So why you have asked palpitation, chest pain, syncopal and all those things?
Palpitations, chest pain and syncope, it will rule out cardiac disease, ma'am.
Yeah. So in elaborating the history of presenting illness, you have taken a negative history also plays a role here. So you're taking negative
history, ma'am.
You have come to a conclusion, the history itself, what could be the cause for all the chief complaints. Okay, so no palpitation, chest pain, syncope, suggests that she doesn't have any symptoms related to the cardiac. And no history
Cardiac
of
illness.
fever. Yeah, fever and chronic cough also can pertain into. So somebody is having a fever also, they can feel generalized weakness, fatigability, all those things. So I have ruled out that. Now, why you have asked history of burning, micturition, increased frequency of micturition? Same thing. And it's because UTI is most common in the pregnancy, that too in the
Most
third
common in
trimester.
pregnancy.
So you have to rule out any infection cause for that. Why it is headache, blurring of vision, all those things?
There's a pre-eclampsia symptoms, ma'am. There's a blurring of vision, headache.
Yeah. So even in pre-eclampsia, though the classic signs and symptoms like headache, blurring with vision, and epigastric burning sensation can be there. Sometimes the patient presents herself with the vague symptom of fatigability and weakness. That could be also be one of the symptom or a warning symptom for pre-eclampsia. So you have asked all these things. Why jaundice, previous history of transfusions and all?
Ma'am, I didn't take history. No history of blood transfusions, ma'am. I didn't write here.
Yeah, you've written that. Why have you asked history of
Why
blood
have you-
transfusion?
Any previous history of anemia, any thalassemia, to rule out that, will take the history, ma'am.
Why jaundice? In what
Jaundice,
conditions that
hemolytic
you
anemia.
find that you have? Yeah. Okay. Fine. Yeah. Go to the chief complaints. We know the three chief complaints. So you have taken elaborately. You elaborated on the chief complaints, and you have taken some negative history to help to come to some conclusion. Okay. So you should know why you have written every sentence there. So go to the next. So then why bleeding per vagina, bleeding per rectum? Does patient tell that she has hematemesis, melena, and all those things?
No, ma'am. Should rule out lower GI bleeding causes, and then any blood loss is there also. It will be the cause for anemia, and then it will cause that symptoms.
Okay.
Like breathlessness.
Okay, ma'am. Good. Go to the next slide.
The obstetric history. Her married life is 1 year. It is a non-consanguineous marriage. Her LMP is 20 January 2023. Her EDD is 27th October 2023. Her gestational age is 35 weeks, ma'am.
How do you calculate EDD?
Nagel's formula, ma'am. 9 months plus 7 days.
Or
9 months from?
Ma'am, 9 months plus 7 days, ma'am.
Yeah, 9 months starting when?
yeah.
9 months from what have you started calculating 9 months?
From last menstrual period, LMP date.
From first day of
From
last menstrual
first day,
period.
last menstrual period date, ma'am.
Yes. So be very
First day
specific,
of last
because
menstrual period. Yes.
if you make an error in these things, then you will be caught by the examiner.
Now,
Okay.
why is it important to know the EDD? Why we are so worried? Is it important to know the EDD?
Yes, ma'am.
Why is it important?
Why?
Is based on we can calculate the gestational age, and then clinic.
No, but why do you want to know when is the EDD for any lady?
You need to calculate so many antenatal management. It depends on your EDD. Like if the patient is
Yes, ma'am.
post-dated or
Management.
she's what is
Preterm
the
or
pregnancy,
post-dated.
37 weeks, is that safe to deliver her in a PHC, or if she becomes a preterm delivery, should be referred to a higher center. So all those things will be based on your EDD itself. Okay, so it's very
Okay,
important to know the LMP and the EDD to date the pregnancy, and dating of pregnancy is very important to manage the whole events of the pregnancy. So very important to know that. But there can be variation. That's why it's very important to have a scan EDD. But this may not be expected in this patient because she is an uneducated patient. So based on her LMP, only we have to calculate the gestation age. But if she had a scan, then we need to correlate with the scan itself. It depends upon menstrual history also. The periods are regular, irregular. If it is irregular, then based on the scan,
First trimester
first
scan.
trimester or
Scan,
NT
dating
scan,
scan.
or anomaly scan, we have to redate the pregnancy, and dating of the pregnancy is very, very important to manage the events of the pregnancy. Okay?
Yes, ma'am.
Yeah, next.
Dr. Sri Lakshmi, there are some very good answers in the chat box also.
Yeah.
Some of them I've answered. One question I want to ask here, Sirisha, how
Ma'am.
does non-consanguineous marriage help or give you a clue here, or why did you ask that?
Any hereditary like genetic disease, hemolytic anemia, hemoglobinopathies, thalassemia.
Yeah, yeah. So since you have a working diagnosis of anemia, you have to support this statement as well. Okay.
Okay.
Carry on.
Yes, ma'am. History of present pregnancy. First trimester, she conceived spontaneously. She confirmed pregnancy by UPT after 1.5 months of amenorrhea. Dating scan was done at 2 months and stroking investigations were done. It was normal. No history of excessive vomiting, no history of bleeding per vagina, per abdomen, pain abdomen, no history of fever or burning micturition, or no history of rash, no history of teratogenic drug intake, no history of radiation exposure, no history of pica, craving for
What are booking investigations that will be done?
routine investigations like complete blood count, blood grouping,
So blood
serology,
grouping and
HIV,
typing. Yeah.
HbA1c, VDRL, urine routine, serum electrolytes.
You would do it as a booking investigation, no? Serum electrolytes.
No, ma'am. Serum electrolytes we won't do. Remaining all. Blood sugar level.
What is the blood sugar? How is it checked? It's FPS, HbA1c, RBS, GTT. What is done?
Random blood sugar we'll check, ma'am.
Random blood sugar?
At first visit.
You won't do GTT?
Want you to do oral
No, ma'am.
GTT?
GTT will do in second trimester, ma'am. Now we will check only random blood sugar.
And what is the cutoff to diagnose pre-existing diabetes if you are using RBS in your center?
126, ma'am.
Come back again.
Mine is 70 to 110. If it is more than 126 before food and fasting blood sugar, and the random is more. If it is more than 140, it's impaired blood.
So it's more than 200 RBS, you call it as a pre-existing gestational diabetes. And if it is more than 140, you have to follow them up with the fasting blood sugar if there's no facility to do HbA1c. Okay, and in the fasting sugar, if it is more than 90, probably you diagnose them as an early GDM. You keep a track and look for the risk factors of family history, BMI, and then you classify it as an early GDM, or you ask them to repeat a fasting blood sugar. But if it is more than 126, as you said, you call them as a pre-existing diabetes. Do you do check for thyroid also in booking investigations?
Yes, ma'am. Thyroid profile also will do.
Yeah. So this whole bunch is called the antenatal ANC profile. Okay, so it has to include all these things.
Okay.
Folic acid, she has taken it regularly.
Yes, ma'am. Folic acid taken regularly.
She's a booked patient and an unbooked patient. And what do you mean by a booked patient?
She's a booked patient only, ma'am. Like.
What do you mean by, according to WHO, how many ANCs visits should they have to call them?
At least 4 antenatal visits within, then we will call it as a booked patient.
That's the old WHO. What is the new WHO guideline? Minimum how many visits?
8 antenatal visits.
Yeah, 8 antenatal visits they should have to call it as a booked antenatal patient. Okay, so how much of folic acid is normally prescribed?
500 micrograms per day.
Okay.
500.
Ideally is 400, but it is not available. We give it as a 500 microgram. Okay, continue.
Second trimester. Quickening felt at 5th month of pregnancy. Anomaly scan done at 5th month and was told to be normal. Iron and calcium supplementation was taken irregularly. 2 doses of injection TD taken. No history of pain abdomen, bleeding per vagina, and leaking per vagina. No history of high BP readings, headache, blurring of the vision, epigastric pain. No history of fever, burning micturition. No history of chest pain and breathlessness.
How do you know that the patient has taken the iron regularly? Through history. How do
We'll
you
ask
understand?
we'll ask her to show the empty strips, or we can ask her the color of the stools.
Very good, very good. Fantastic. Okay. So if there's a change in the color of the stool, or if she's telling that she has some amount of constipation and all those things, then we can indirectly conclude that she is taking her iron regularly. Okay. So what is the other cause? Why people, I mean, usually the antenatal pregnant ladies are not very keen to take iron tablets?
Is it gastric discomfort, intolerance with the constipation,
Gastritis, okay,
gastritis.
constipation. Okay, so usually they tend to avoid it. So by giving an antenatal education, we can increase the compliance. Okay. So now what is the dose of iron that is required? That is given in this as a supplementation.
From
Elemental
from
iron.
4th month onwards, we will start 60 milligrams of elemental iron. We will give, ma'am.
Okay.
For 180 days at least. We will give.
What is the guideline, ICMR guideline regarding that?
For
These are the questions
prophylactic
that will
dose, OD we will give, ma'am. At least 1000 milligrams of iron we can give in 180 days.
So how does it get supplied in the government setup? So 100 mg of elemental iron has to be given after 12 weeks of pregnancy or 14 weeks of pregnancy, and minimum it has to be taken throughout pregnancy and also up to 6 months.
Postpartum 3 months, ma'am.
Postpartum 6 months, ICMR, WHO at least 3 months it has to be given. Okay.
Yes, ma'am.
So, and what instructions do we give to the patient to take the iron? It has to be told to them, no? What are the
She
instructions?
has to take iron before meals, 1 hour before the meals, or 2 hours after the meals she can take, ma'am.
It has to be taken 1 hour in an empty stomach, it has to be taken, or at
Empty
least
stomach.
1 hour later it has to be taken, and then it shouldn't
Not
be
together
combined.
with the calcium also.
Yeah, it shouldn't be combined with the calcium. Okay, so
Calcium.
that's how you increase the absorption of iron.
Yes, ma'am. It will.
Any other investigation which has been missed in the second trimester, which you have not entered?
Here, OGTT I missed, ma'am.
Yeah.
Glucose tolerance test.
And how often do you check the hemoglobin in pregnancy? In a booked patient?
At least 4 times.
Yeah.
In the first trimester once, second trimester once, third trimester at the time of delivery also we'll check once. At least 4
Tell
times.
in terms of gestation age.
At what time?
Yeah.
Yeah.
In the first trimester, at first visit we will check once, ma'am. And then 20
It's
to
called the
20.
booking visit. Yeah, booking visit,
Yeah.
or when you're doing the blood
Booking
investigation, you do it. Then
And then in between 20 to 28 weeks, we'll check once. At the just 32 weeks, we'll check once. And then at the time of the delivery, 36 weeks after, we'll check once.
so minimum is at the booking visit when you're doing the other investigations, 24 to 28 weeks when you're looking for the OGTT, because at that time the insulin resistance is high. So you look for a GTT again. With that, you can combine the hemoglobin. There's no need to get the patient pricked twice, once for the sugar, once for the hemoglobin, then at 32 weeks and then at 36 weeks. Okay, you should answer in this way.
Okay.
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 So what will happen to the iron requirement in pregnancy? Can you briefly tell about that?
Ma'am, in first trimester, 1 to 2 milligram per day. And the second trimester, 4 to 5 milligram. In third trimester, 6 milligram per day, ma'am.
But why are you giving 60 milligrams of supplemental iron then?
Hello?
So why are you giving them 60 milligram per day?
Ma'am, 60 milligrams, only
Yeah,
10% only
6
will
mg
absorb,
per
ma'am,
day,
in the
Hello?
only 6 mg per day, ma'am.
Yeah, but
Hello,
why
ma'am.
are you giving 60?
Ma'am, iron absorption, in the total amount, only 10% will absorb,
Yeah,
ma'am.
very good. That's the answer we required. Okay. So 10% gets absorbed. So she goes with the 6 milligrams itself. Okay.
6 mg
So,
per day. Yes, ma'am.
yeah, what is the total requirement of iron? These are the common questions. That's why I'm asking you. So you require total iron
1000
requirement.
milligrams.
So why does it, in what composition it is divided to the mother and to the baby?
In 1000 milligrams,
The
500.
requirement of the placenta, there's an increase in the RBC of the mother. Okay, there's fetal RBC formation. fetal-placental circulation. So
Yes, ma'am.
including all those things, and also the loss also to take into consideration. She requires
200 milligrams will lose.
1000 mg of iron in her whole pregnancy. That's how we have to put across. Okay. So usually sometime there can be question also regarding where the iron gets absorbed. What are the factors which will impair the iron absorption? What are the factors which will increase the iron absorption? What are the food which are rich in iron? So these are the common questions for which you should know the answer as a family medicine postgraduate student, because you may have question of anemia even in non-pregnant ladies also. Even in medicine this question can be asked. So I leave those questions because we have a lot more to ask in pregnancy related anemia. So go to the next slide.
Patient continued to pursue the fetal movements well. History of irregular antenatal checkups. History of swelling of both limbs since 1.5 months. Hemoglobin was low at the time, 7.8, twice daily. Iron and calcium supplements was taken irregularly. No history of burning micturition and increased frequency of micturition. No history of fever.
Sirisha, you had told her booking investigations are normal. So how much was her hemoglobin at the time of the first antenatal visit?
Ma'am, don't know, ma'am. At the time,
You wrote booking investigations were normal,
was
no?
done. Yes, ma'am.
So how much was it?
Patient told it is 11 to 12 like that, but she also not told correctly, ma'am. Like
Patient, if she's
11 to 12.
uneducated, how will she tell her hemoglobin?
In her language, how much blood was there, like that we asked, ma'am. She told it was normal, 11 to 12 it was, like that she told, ma'am.
It's not convincing, but yeah, because you have written over there booking investigations were all normal. In this case, again, it becomes significant.
Yes, ma'am. Yes, ma'am.
Now we have written irregular antenatal checkups.
Regular,
Yeah. What should be the normal regular antenatal checkups? We have told according to WHO minimum 8 checkups should be there, but somebody is booked, well booked. So how often do we call them for the antenatal checkup, starting from the booking visit?
Up
Can
to
you elaborate that?
Ma'am, up to 28 weeks, it is monthly.
Yeah, good. Then
monthly once.
Sirisha, your voice is breaking.
So up to 28 weeks, you call them once in a month, and up to 36 weeks, you call them once in 2 weeks, and after 36 weeks, you call them every week until the EDD. So that's simple, very simple. You can answer that. Okay. Do you do routinely the growth scan at the 3rd trimester?
Sirisha, your voice is breaking, Sirisha.
To 32 weeks.
We can't hear you now.
After 32 weeks, weekly once will tell her to come.
Can you hear us? Dr. Sirisha?
She's logged out again. She's joined.
Joined back, yeah.
So I'll repeat that. Up to 28 weeks, once in 4 weeks. Up to 36 weeks, once in 2 weeks. And very easy to remember. After that, weekly, we call them up to the EDD. Okay.
Sirisha, can you hear us?
Okay, ma'am. Yes, ma'am. Yes.
Okay, can you sum up your, finish your history, ma'am? Dr. Sirisha, complete your history.
Yes, ma'am. Menstrual history. Yes, ma'am.
Yeah, we can hear you.
Her cycles are regular. Duration of the menstruation is 4 to 5 days per 28 days. Amount of the bleeding is moderate flow, not associated with dysmenorrhea, passage of clots. No history of contraceptive use. Past history, not a known case of hypertension, diabetes, tuberculosis, asthma, epilepsy, not a known case of thyroid disorders or cardiac diseases. No history of any hospital admission, blood transfusion, surgery in the past. No history of chronic drug intake.
What do you mean by chronic drug intake? What was in your mind when you asked this question?
Any thyroid disorders,
Yeah,
they will
but
take
nothing is
daily
there.
No,
one.
you've already written thyroid, but what is
Yeah.
chronic drug? What did you think of when you asked her or when you wrote this point?
It's just
Any
health
other
chronic.
painkillers,
Yeah.
they are daily wages, na ma'am. They may take NSIDs daily.
So what will happen if they are taking NICDs?
Mm.
Pertaining to your history of keeping in mind anemia,
Yes, ma'am.
they can have bleed, no?
GI bleed. Yeah, gastric erosion.
Gastric erosions and
Yes.
some, yeah. So
Correct.
that's how you should correlate your history, just like not taking everything as, so you have to fit into your case. Okay, yeah.
Gastritis.
So that's
Okay.
apt to cardiac diseases you have ruled out. So
Okay.
it was in your mind that probably whether she has a cardiac disease, that's why she's having fatigability and bleeding and breathlessness. And you have ruled out with this past history of no history of blood transfusion or hospital admission, that there's no this one inheritable cause for her anemia like thalassemia or sickle cell, anything like that. So all these things have been ruled out with this negative history in the past history. Okay. So next, go to next slide.
Yes, ma'am. Family history, no history of chronic diseases in the family, no history of genetic disorders or blood diseases in the family, no history of multiple gestations or congenital anomalies in the family.
Okay.
Personal history, she's a mixed diet, preferably vegetarian, good appetite, she has sleep is adequate, bowel and bladder habits are normal and regular, no addictions are there.
What did you miss in the personal history? Very important. Drug allergy, very important. No, you want to treat her. Medications.
Yes,
Okay,
ma'am.
very important. Never miss the drug allergy history. Okay.
Okay.
Yeah.
Also in diet, of course, you've written mixed and preferably vegetarian. But since she's a daily laborer and all of that, you have to also ask in detail about her to get a clue about her nutrition status, especially in anemia case.
Okay, ma'am.
What will happen to the calorie requirement in pregnancy?
Yeah.
It will increase, ma'am, calorie requirement.
Yeah, of course it will increase.
Yeah.
So
So
350
preferably in
kilocal.
your diet, you have to ask in a recall method what are the things she eats for her breakfast, lunch, and dinner.
Yes.
And, roughly, you have to make a calculation whether she's taking it or not. Because I think it is very important for a family medicine people to know this, I believe.
Yes, yes.
Has to be done in detail. It is not just like this diet mixed, preferably vegetarian.
You have to have the detailed
Yeah.
diet. Correct. Yeah.
Okay. Fine.
Okay, ma'am.
Next, you go to examination.
General physical examination. Patient examined in sitting position. Patient is comfortable during examination. Patient is conscious, coherent, and cooperative. Patient is moderately built and poorly nourished. Height is 155 centimeters. Weight is 44 kgs. Her BMI is 18.33 kg per meter square. Severe pallor present. Grade 2 pedal edema up to ankles present in both lower limbs. No icterus, clubbing, cyanosis, generalized lymphadenopathy, ma'am.
What do you mean by severe pallor? How do you assess pallor? How do you grade pallor if you have written severe pallor?
Palmar creases will look pale, and the mucous membranes will look pale.
Which
Which
mucous membrane?
mucous membrane? How do you assess pallor? How do you look for pallor in a patient?
Mucous membranes is like oral mucosa.
Yeah.
Then?
And then oral mucosa, tongue, and the nail bed we will see, ma'am.
One very common first thing that you see in
Nail
your OPD?
creases will see, ma'am.
Huh?
Sorry, palmar creases, ma'am.
One more? On the face?
Eyes. Palpebral conjunctiva.
Palpebral conjunctiva, I told.
Albuterol conjunct for everybody, it looks red only according to me. So where do you look for it? So you have to look in the conjunctiva. Which conjunctiva?
Palpebral, lower.
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 You have to pull down the eyelid and
Eyes
look
down.
at the inner edge. Okay.
Yes, ma'am.
Okay. So how do you grade it now? You have written severe pallor, no, Sirisha. So mine
So,
moderate
Yes, ma'am.
severe means
yeah.
how
Palmar
big?
creases are not looking prominent. Then we'll call severe pallor, ma'am.
So if you see only the pallor in the conjunctiva and in the mucous membrane, that is in the tongue and the oral cavity, you call it as mild. If it is further on the hand, you call it as moderate. If it is even the creases are not able to be made out, so much is the pallor in the hand, then you will call it as a severe pallor. Okay, so severe pallor will correlate with the symptoms of fatigability and weakness and the breathlessness. Okay, so what is grading of fetal edema? If you have written, you should know. No, if you have written only fetal edema, nobody would have asked this question. You are only making the examiner to ask questions by grading it. So now we are asking the grades.
Ma'am, when we press above the medial malleus for 30 seconds, based on the depth of the skin deepening, we will grade edema, ma'am. If it is 2 mm, it is 1 to 2 mm is grade 1. 2 to 4 mm is grade 2, ma'am. Grade 3 is 6 to 8 mm. If
Continue, Krisha.
more than 8 mm is grade 4, ma'am.
So very simple. If you want to grade it is you press and see how much time you're able to, how much time are you taking, how many seconds are you taking to press it, or whether it is getting corrected immediately. Based on that, you grade it. Okay. So probably grade 2 is you need to put a pressure for a longer, for less minute, and it is taking time to reform again. To rebound again, it is taking time. So it is a grade 2 fetal edema. Okay.
Yes, ma'am.
Yeah.
Okay.
Why did you ask icterus?
Any hemolytic anemia we can rule out with icterus, ma'am.
Yeah.
So yeah. Next, ma'am.
Stomach examination. Vitals, her temperature is 97.5 degree Fahrenheit. Pulse rate is 102 beats per minute. Regular in rhythm, normal volume, no radial and radiofemoral delay. Peripheral pulses felt. Her blood pressure is 110/70 millimeters of mercury, measured in the right arm in sitting position. Respiratory rate 24 cycles per minute. Her JVP is normal. Breast, thyroid, and spine are normal.
How do you check blood pressure in pregnancy?
In sitting position.
Sit. She's not able to sit. She's admitted. What do you do?
In supine position, we will check.
Yeah, supine position, or if it is in the
Left
open
lateral position, we will check.
Yeah, she should keep her back straight, or back supported her back, and both feet should be touching the floor. She has to be relaxed in an OPD. Immediately she rushes to the OPD, you check her BP, it will be high. So make sure she's calm. She's waited for 2-3 minutes. Okay, she has emptied her bladder. She's relaxed, and then you check the blood pressure in the sitting posture in the OPD with the hand supported at the level of the heart. Okay. So
Yes,
what is important in checking the blood pressure in pregnancy compared to the non-pregnant ladies? What will happen to the auscultatory sound?
Ma'am, not able to understand question.
So usually when do you know that when you're checking in an auscultatory method for the blood pressure, no, you hear the first sound, and that is the systolic. Sometimes you may not hear the last sound at all, no, feeble sound in pregnancy.
Yeah, diastolic may not be.
May not be heard. Okay.
Yes, ma'am.
Okay, that is very important. Then that pummeling of the sound itself is taken as a diastolic blood pressure, especially a very lean patient, thin patient, you can have all these issues. Okay, and you should be very clear. Some examiners may ask regarding in detail the measurement of the blood pressure itself. or how it is taken, what should be the length and breadth of the cuff, does it depend upon the BMI of the patient? So all those things has to be appropriately answered, because knowing blood pressure is very important in pregnancy for our manager, especially the patient when she has complaints like this. Okay?
Okay. Okay, ma'am.
Okay, carry on. So JVP is normal. What does it suggest?
Right heart failure, ma'am. If any heart failure is
The
there,
JVP is normal.
Normal. So it suggests that there is no,
No
no
cardiac
elevation, no heart
yeah, no
failure,
elevation means there's no cardiac failure.
no cardiac failure.
Yeah, very important to write this point pertaining to your history. Okay,
Yes, ma'am.
carry on. Ma'am.
Systemic examination, cardiovascular system examination, S1, S2 here, no murmurs heard. On respiratory system examination, normal vesicular breath sounds heard, no added sounds. On central nervous system examination, it was normal, no neurological deficit was there. On gastrointestinal system examination, no organomegaly.
So ideally at this stage of pregnancy, there's no need to write no organomegaly, because the womb
Yeah.
is the
Yes.
uterus itself. Okay, so
Okay.
where can you feel this splenomegaly, hepatomegaly? Nothing can be seen. Nothing you can palpate. Because
You cannot palpate. Yeah.
so
Don't
you
write something
this.
and get
Okay.
stuck.
Yeah, as a
Okay.
routine you would have written, but please make sure that you won't write it when you are examining third trimester patient. Okay.
Okay, ma'am.
Yeah.
Also, in anemia, what type of murmur can be heard?
Yeah.
Ejection systolic murmur will have, ma'am.
Or pansystolic?
Yes, ma'am. Ejection systolic, yes, ma'am.
So in this you didn't hear.
No, ma'am, I didn't heard.
Okay.
Parabdomen examination. On inspection, abdomen is uniformly distended, longitudinally ovoid in shape. Suprapubic region is convex. Umbilicus is central and everted. Linea nigra and stria gravidarum present. No scars, sinuses, dilated veins noted. Fetal movements are visible. On palpation, fundal height corresponds to 32 to 34 weeks. Symphysis fundal height is 32 centimeters. Uterus was relaxed. Liquor is adequate.
How can you tell the liquor is
How do
adequate?
you know? Yeah.
Fetal parts, if fetal parts are well palpated, easily palpated, that is inadequate. It is normal means it is adequate. Like,
What will happen if there's a polyhydramnios? You feel the, it's difficult to palpate the
Yes,
back and the limbs of the baby, and you feel there's a lot of, you can feel that though there's a lot of water around the baby. Okay, easily the parts will not be palpable, and also the symphysis fundal height will be more, abdominal girth will be more, or sometimes the skin, if the polyhydramnios is so much, there can be shiny skin also. But if it is the liquor is less, you may have the symphysis fundal height also can be less. Okay, so
Less.
usually what will happen to the symphysis fundal height from when you start checking it?
after 28 weeks, we'll start checking.
Yeah, ideally 24 weeks. And how do you correlate? Usually it will correspond in
To
centimeters
gestational age.
gestations in the gestational period in weeks. If it is plus or minus 3 centimeters from the gestational age, probably you have to think whether it is, if it is more, you have to think of polyhydramnios, macrosomia. If it is less than 3 centimeters in gestational age,
IUGR.
then you have to look for IUGR. So when you have the symphysis fundal height lesser than the gestational age, and also you can easily palpate the fetus and see the movements well, probably you have to think about the less liquor. Okay, that's how you should answer. You didn't check the abdominal girth. Usually it's a part of the examination.
The first one.
I have
Yeah,
to
first
mention
one.
it. Yeah, I have to mention the abdominal girth also. And the abdominal girth is taken at what level? At the level
of umbilicus.
8 centimeters. Okay. Carry on.
Obstetric grips. Fundal grip shows soft, broad, non-palatable fetal parts felt, suggestive of breech. Lateral grip on right side, smooth curved fetal part with uniform resistance, suggestive of spine. On left side, irregular knob-like structure, suggestive of fetal limbs. First pelvic grip shows hard, globular, palatable part, suggestive of head is not engaged. Second pelvic grip, head is not engaged.
Carry on, carry on.
On auscultation, fetal heart sounds are present in the right spino-umbilical line. Fetal heart rate is 150 beats per minute, regular rhythm.
Okay. What is your diagnosis? Yeah. Provision
A
diagnosis.
22-year-old primary gravid at 35 weeks of gestational age and booked case belonging to low socioeconomic status, presented with complaint of easy fatigability, swelling of both lower limbs and breathlessness, irregular antenatal checkups, non-compliance to the oral iron supplements. On examination, poorly nourished with pallor and grade 2 pedal edema. Then mild tachycardia is there, ma'am.
So what's your provisional diagnosis based on the history and examination?
So a 22-year-old primary gravid with 35 weeks of gestation with single live intrauterine fetus in longitudinal lie and cephalic presentation with severe anemia, not in failure for further management.
Correct.
Good. Okay, then what did you do? How do you manage? Now, what is this grading of anemia in pregnancy?
Grading of anemia, according to WHO, if it is 9 to 11 is mild, and then 7 to 9 is moderate, 7 to 9 is severe, less than 4 to 7 is severe, less than 4 is very severe, ma'am.
How do you, I mean, based on the value of the hemoglobin, how do you diagnose anemia in pregnancy in the first, second, and third trimester, the postpartum period?
Less than 11 gram percentage according to WHO, ICMR, ma'am.
In
In
which
what?
trimester? In the first trimester, less than 11, second trimester, less than 10.
In according to the CDC, first and third trimester less than 11 gram percentage. In second trimester less than 10.5 gram percentage.
Why is there why there's a concession of 0.5 grams? What is physiological anemia?
Hemodilution will happen, mama. In physiological anemia, the plasma volume will increase.
So
That
plasma volume increases by 50%, but the RBC
yes, ma'am.
by 20-30%. So there is a hemodilution which will cause
Dilution.
physiological anemia in the second trimester of pregnancy. Okay. So why does that happen? It is happening
Plasma.
naturally. Yeah, there should be some reason. So that will improve the placenta fetal circulation, and also it will compensate for the loss which will happen during the labor. Okay, so plasma is lost than the RBC. So some mechanism to protect the mother itself, the nature is doing that. Okay, so you classified severe, now severe anemia. What is the hemoglobin now? Coming to the investigations. Investigations were done. What
Her
investigations were
hemoglobin
done?
now it is 6.9 gram percentage, ma'am. Her hemoglobin.
So what investigation do you order now? She's admitted.
You have
Complete blood
suspected
count.
anemia. Yeah.
Yes, ma'am. Complete blood count with the peripheral smear. After doing that, we'll go for further investigations like iron studies.
Based on?
Based on the peripheral smear and MCV,
Yeah.
we'll see MCV and hematocrit values.
So the MCs, you get a CBC done, you look for hemoglobin and correlate with your hematocrit value, and also look for MCV. Based on your MCV, low, high, or normal, you order the further investigations.
Yes, ma'am.
So now she's how many weeks of pregnancy? 32 weeks of pregnancy.
35
weeks.
35 weeks of pregnancy. So how do you want to treat her? So now what with the CBC, you came to what conclusion now? What type of anemia? What are the...
What about peripheral
severe
smear
anemia
in this case?
Peripheral smear showing microcytic hypochromic RBCs, normal total count with a normal red cell distribution, platelets are adequate, no hemoparasites are seen.
So without iron studies, so can you come to conclusion what type of anemia based on these two tests?
We'll come to iron deficiency anemia.
Okay. Now how do you want to treat her?
6.9 means it will come under severe anemia, ma'am.
Okay.
At 35 weeks with severe anemia, we can go for parenteral iron therapy or blood transfusion also we can give.
What do you want to do? Then you have to answer the pros and cons of the iron infusion and also with the blood transfusion. So you have to tell the pros and cons of each one of them, debate it. And in this case, which is better? Because she's 35 weeks of pregnancy.
Also, patient may ask you or the relatives may ask you why the less hemoglobin is a risk. What is she at risk of?
What are the effects of
May
anemia?
lead to complications like heart failure, PPH, postpartum hemorrhage.
Preterm labor?
Yes, ma'am. Preterm labor also.
Yeah, that is one first thing you have to tell them, no?
So any effects of any disease in pregnancy, whether it is anemia, whether it is asthma, whether it is a cardiac disease, you have to always divide it into effect on the mother and effect on the baby. Okay, you have to classify like this and you have to answer. What will happen to the mother and what will happen to the fetus, you have to explain to them. Okay.
Yes.
So at during the pregnancy, because of the anemia, if she had not turned up to her and she had a severe anemia, at what gestational age she's at a high risk, at what stage of pregnancy and labor, she'll be at a high risk for cardiac failure. If she had not turned up to you.
Postpartum, ma'am.
Hello.
Postpartum, ma'am.
Postpartum, during second stage of labor, and also in pregnancy, at what stage she's at a high risk of cardiac failure?
Stage 2, stage 3, ma'am.
In pregnancy, when will be the cardiac output increases maximum in
Second
pregnancy?
trimester.
Yeah, 32 weeks.
32 weeks.
Cardiac
Okay.
output is maximum. She's unable to manage it because already she's in severe anemia. Okay, so those are the stages in pregnancy and during the labor, second stage, and immediately after the postpartum, she's at high risk of failure. She has to be very vigilant during the labor if somebody is like this, having a severe anemia. Now, how do you want to treat it? You want to give a parenteral iron. Why you want to give it? If you want to give a blood, a PRBC, why you want to give it? You have to debate it. She is admitted
Please,
now.
35 weeks, we can go for blood transfusion.
Yeah, more than 36 weeks, ideally, you have to go for a blood transfusion. Why that cutoff of 36 weeks? What is in your mind that it is 36 weeks? Because even if
may
you
lead to labor.
yeah, even if
She
you
may
give,
deliver. Yes,
oh no, even if you give iron or even if you give an IV,
that will take some time to
supplementation,
improve.
it takes time. How much time for her to pick up her
At least 3
hemoglobin?
to 4 weeks time.
Yeah.
Yeah.
Pick up how many grams?
Uh,
1 to 2 varies.
1 to 2.
1 to 2.
1
So
to
she's
2.
already 35. So you
Yes,
can wait up to 37 and see, and you can give the parenteral iron itself. But if somebody is 36 weeks, you can't sit and wait on them for next 3 to 4 weeks. She may go into labor. How many
Yes,
people will deliver on the date of EDD among 100?
1
How
to
many
5%.
will deliver? 3 to 4%. Okay, among 100, 3 to 4 will deliver on the date of given. EDD given. The rest of them, 80% will deliver at least after 38
Before or
weeks.
after.
Okay, another 10% may deliver after the EDD also.
Yes,
So we are worried there that she may land up in preterm delivery also because they are prone to have a preterm delivery. Because they are more prone for infection, anemia, more prone for infections. So infection itself can push them for the preterm delivery. So here you can argue both ways of giving iron infusion also, and you can also go for a PRBCs. But when you are giving a PRBCs, the blood transfusion, you have to be very vigilant regarding the reactions and all those effects of transfusion. HIV, HPCG being transferred, it is not clearly matched or mismatched. So preferably we want to give her iron infusion and wait and see. Okay, what are the iron preparations you know of?
Oral iron, so parenteral iron,
Parenteral iron.
iron dextron, iron sucrose, ferrous carboxymaltose, ferrous gluconate.
How do you calculate the iron requirement? Now we want to give iron infusion to her. So how do we calculate?
We should calculate iron deficit by Ganjan's formula. 2.4 into body weight into HB deficit plus 1000 milligrams of for stores, ma'am.
Okay, weight in what?
Weight in kgs, ma'am.
Which weight and now this what
pre-pregnancy weight
now
we will take.
Yeah, pre-pregnancy weight, and you have to
calculate the iron deficit.
Now this patient, how she will know whether she has what is the pre-pregnancy weight?
Or otherwise, we can take first visit weight. We can take. Ma'am.
Ideally, usually, so it's a logic now. Okay, so how much weight gain will happen in this low socioeconomic status? That's how you should calculate. Okay, so ideally, if they're fed well, or ideally they have to have at least 10 to 12 kgs of weight should be put on. But in this low socioeconomic status, now she's weighing around 55, probably she would have gained another 3-4 kgs. That's how logically, if nobody has entered or she has not gone for an ANC at all. So usually you see such patients in flocking into the government setup as a tertiary care without ANCs. So that's how logically probably you put her, now she's 55, you put her as 52 or 50 and you have to calculate iron requirement and you have to transfuse to them. Okay. So,
Okay, ma'am.
I mean, what are the precautions you need to take when you're giving the iron infusion? You need to, if you are using sucrose or FCM, Dextron, I think nobody is using now. So do you want to give her a test dose? Is it required?
For iron sucrose, no need, ma'am.
Okay, even FCM.
Yes, ma'am. Iron carboxymaltase also.
Okay, so what do you use in your center? Polar.
Iron sucrose only will use.
You use iron sucrose. Okay, now if you want to give the PRBCs, do you want to give her a pre-medications? Want to give?
Lasix we will give. Before giving blood transfusion, we will give Lasix, ma'am.
What is Lasix, Sirisha?
Frusi, ma'am. Frusi, ma'am.
Yeah. Please don't use brand names.
Okay, ma'am.
Okay, now you have given the iron. How much iron? If you want to give the PRBCs, how many things you want to give her? How many PRBCs you want to give her?
One pack per day we can give with all 24 hours gap we can keep, ma'am. Like
How much you want to give her in this? Now she's admitted. She'll ask.
four
relate-
PRBC you can transfuse.
4. Minimum, how much the hemoglobin should be to push her into the labor, or you want to take a
10
prescription?
10 gram, ma'am.
Yeah,
3
each institution will have a different thing. But at least 9 is more than enough to take them to the labor. But if you're somebody is less than 10 and she's already landed up in labor, or you want to take her for an elective LSCS for any reason, it is always good to cross match and reserve 2 pins of blood. Now she has landed up in, imagine she has landed up in labor. Okay. So what are the precautions you want to take? Can you allow her to go into normal vaginal delivery? You have given her blood yesterday because of the blood itself. Sometimes the blood transfusion itself, sometimes it can trigger preterm labor. Now she has gone into the preterm labor. So what precautions you want to take? You want to allow her for a vaginal delivery? You want to do section for her because she is having
No, ma'am.
severe
We can allow her for vaginal delivery.
which
And
is
then
best.
postpartum also we can arrange blood and we can transfuse, ma'am.
What are the things you have to reserve 2 pins of blood on hand?
Yes, ma'am.
Keep it ready. How do you manage your first stage of labor?
Make the patient in propped up position, make everything
Proper
ready
position,
for oxygen.
check on her oxygen status, okay? And control the IV fluids. You shouldn't rush the fluids, okay? So make sure that
I
it's
make
not more than
slides for that,
125
ma'am.
ml, okay? Then
oxygen, intermittent
has
chest
written strict
auscultation.
asepsis,
Yes, ma'am.
okay? Okay. Then
Intermittent chest auscultation, strict asepsis, labor monitoring by partograph, CTG monitoring, sedation and analgesic, and then fluid restriction
Yeah.
in the first stage, ma'am.
so labor analgesia has to be given, because what will happen if you give them labor analgesia, the pain is reduced, that hypoxia will be reduced. She won't breathe heavily. Okay. So that anxiety, when everything is reduced, the oxygenation to the brain and to the fetal-maternal circulation will be better. That's the reason you give them the sedation and analgesics. Okay.
Okay.
So second stage of labor, you have to give, as you have written, oxytocin in a concentrated form, and you can cut short the second stage of labor, because when they are pushing, that itself
More
can
bleed.
increase the pressure on the heart. The
Heart.
yeah, the heart increased output from the cardiac output can be kept at a bay when you cut down the second stage of labor. Okay.
Yes, ma'am.
So what do you mean by the active management of third stage of labor? You're in which year, Sirisha?
Ma'am, first year.
You not entered the labor room yet.
No, ma'am.
Okay.
Finished, ma'am. Labor room is finished, ma'am.
Then you should answer at least this active management third stage. What do you mean by that?
Prevention of PPH, ma'am.
It is a management to prevent the postpartum hemorrhage. What do you mean
Yes,
by that? You are giving a immediately
uterine
after the
massage you
delivery of
give
the anterior shoulder of the baby, you give them according to WHO 10 units of
10
oxytocin.
units of oxytocin we will give,
IM,
ma'am.
IM, okay.
Yes, ma'am.
So then you have to do a control cord,
Control cord
separation of the placental
contraction.
spines and do a control cord traction. So this is the active management of third stage to prevent PGH, because this is very important. This is routinely done for all deliveries, but more so you have to be vigilant in doing it in a woman who is having severe anemia, because the minimum amount of hemoglobin she has, even if she loses that also, there's increased chance that she may go into failure. Okay.
Yes, ma'am.
So you have to be very vigilant in the third stage of labor. Then what is the fourth stage of labor?
After removal of the placenta, monitoring for 2 hours, ma'am, post.
No, it's 4 hours. 4 hours she has to
Hours.
be kept in the observation in the labor
Under observation. Yes.
or in the triage area to look for what?
Postpartum hemorrhage, ma'am, for PPH, and then uterine contraction. We will see any uterine atony is
Look
there
for
or
whether
no.
uterus is well contracted, whether
Well
she's the
contracted.
baby. Okay, and make sure that she has emptied the bladder, because if the empty bladder is not emptied, that itself can trigger the postpartum hemorrhage, and it is very hazardous to the woman who is already having anemia. So you have to keep them for 4 hours. Make sure that the uterus is well contracted, her vitals are stable, and she has fed the baby and she has emptied the bladder. Then you shift her to the ward. Okay, even in the ward, you have to be vigilant enough. Okay, for the next 3-4 days, she has to be kept under observation. You want to give the blood now, even if she had not had a PPH and everything was fine. You want to give her the PRBC now because you had reserved and kept.
We'll check hemoglobin again, and then we'll keep, according to that, we'll keep iron therapy, ma'am.
Okay, yeah. Based on the hemoglobin after 24 hours after the delivery, you want to check, because you want to wait for the redistribution to happen and then check the hemoglobin. And based on her symptoms, just because you have reserved and kept 2 pins of RBCs, you don't want that to get wasted. Don't pump that blood to the woman. Okay, it's not, we have to utilize it whenever it is required only. If she's tachycardic, if she's giddiness, she's not able to move around. She's symptomatically having severe anemia, less than how much should be the hemoglobin to transfuse in the postpartum period? Same thing, less than 7. I think holds good here also. Then only you have to transfuse. Other than, if not, you can again give her another dose of iron infusion. Okay. So and she has to continue this iron therapy at least 6 months, 3 to 6 months. And you have to give the, why you have to give the contraceptive advice now itself here? What is in your mind?
Spacing, ma'am.
Yeah, very important, because she needs to replenish the stores. Okay.
Stores.
Otherwise, if she conceives again, minimum how many months of gap?
2 years. Sorry, ma'am.
Minimum should be 18 months. Okay.
18 months. Okay, ma'am.
Yeah. Okay. To replenish her stores of iron stores, you have to advise her appropriately regarding the contraception. Okay.
Okay, ma'am.
Yeah. Anything else, Dr. Jyotika?
No, I think this was quite comprehensive. I think any questions from the audience, you can put it in the chat box. But I think most of them have answered it also, as you asked. I think this management in labor, different stages is very important, Sirisha. And of course, management in the postpartum stage. So antibiotics, iron therapy should continue at least for 6 months. This is important as a family physician also. So once she gets discharged and goes home, then she will be under your care, and you know how to advise her to plan the next baby. Also advising the family, rather even the husband. That is important, not just advising her.
Okay.
Also nutrition advice once she goes back home.
The other questions commonly asked in anemia is what are the different causes of anemia, which is the most commonest cause, and probably 1 or 2 questions on what is sickle cell, what is thalassemia.
Yeah.
This can be asked. And the other question is iron metabolism. Very important to know it very in depth, because as I told you previously, pediatrics, medicine, and OBG in all 3. This one you can be asked these questions. Okay. Anyway, they can ask you. So this much if you know, and different oral preparations of iron, very important. How much will be the absorption? what is the amount of elemental iron in each of these different iron preparations. It's very, very important. Okay.
Okay, ma'am.
Any questions?
Yes, Akshay, maybe you can, any questions? Can wrap up. I think this was
There is
really-
one common treatment of mild anemia in pregnancy if patient is compliant on oral iron.
Treatment of mild anemia if patient is compliant on oral iron.
Yeah.
Then you have to look for, I mean, if the anemia is still there and she tells she's taking iron, oral iron, then you have to look for a serum ferritin level, what is happening. But if it is a mild anemia, most common cause would be, I believe in our practice, what we see is thalassemia. Okay, so
Yeah, that's what I was about to ask.
yeah, thalassemia is the most common cause. So then you have to look for a hemoglobin electrophoresis.
Okay.
So you are pumping iron and she's telling she's taking it regularly, she's pumping, and still the hemoglobin is not raising. Always better to look for thalassemia.
Okay. Yeah, I think that was the last question, ma'am.
Yeah, I think there are no questions.
For a first year, Sirisha, you did very well.
Yeah.
You should be bold enough to answer, nothing to get. It's just you're not in the exam, right? It's a learning process. But anyway, for the first year, you did very well. Congratulations.
Also, Dr. Srilakshmi, actually, they are diploma students. So there is this diploma family medicine that has started, no?
Okay.
So, that program is still not well designed like DNB. But yes, Sirisha, I think you were really good. Of course, we could sense that you were tensed.
Yeah.
But even with that, you answered really well.
Thank you.
Yeah. Now, I think you'll never forget anemia in pregnancy, whether
I
exam
read so
or
much for this case
practice.
presentation, ma'am.
No, Sirisha, you were really good.
Yes.
Yes,
Thank you.
yes. Okay, so thank you, Sirisha. Thank you, Dr. Jyotika. Thank you, Dr. Srilakshmi. We had a very nice session, I think. I hope for all the students, it was a very comprehensive class, and I don't think there was any aspect left out.
Yes,
So,
I think entire anemia was discussed.
yes. So I hope if any of them end up getting this case in their exams, I'm sure all of them are going to ace this.
Yes.
Yeah.
Also, this session recording will be available on our YouTube channel in about 1 or 2 days. So whoever has not missed it, whoever has not attended, or at the time of exam when you want to revise, and Sirisha, when you want to recollect how you presented, you can always go through.
Thank you so
And
much,
the
ma'am.
Spice Route for this opportunity. Okay.
Thank you.
Enjoyed.
Dr.
I
Lakshmi for
read a
joining.
lot.
Thank you.
Even I read a lot.
Thank you. Thank you so much. For me, it was like re-attending my class.
Thank you.
Thank you.
Thank you.